Thank you so much. I'm going to ask a few questions, and then I will yield to Mr. Richmond, our ranking member, and we'll go from there. My first question is for you, Ms. Trudell. The meaningful use. You touched on it in your opening statement. Can you once again reiterate what it is and how it is that physicians and hospitals are adhering to it? Because that's obviously the proof that they have to provide.
I'll walk through some of the core requirements for meaningful use, and I think that will give you a good idea of where we're trying to go with that. A number of the core requirements focus around capturing data in the electronic health record so that it can be used over and over for clinical reasons. Some of those include capturing a list of current and active problems, medication lists, vital signs, allergies, smoking status, demographics. So those are the things that we're capturing in the EHR. Then there are some things that are action-oriented, like computerized provider order entry and electronic prescribing, and, of course, the privacy and security requirements.
What would happen if a physician did not actually what would happen if they weren't able to provide that information to you?
For this first year, and again, this is a voluntary program, the provider can register for the program and then has the entire year through to February of 2012 to report that they have meaningfully used for a 90-day period of their choosing. So they can decide what that period is. They track these requirements, make sure that they've met them, and at that point they would sign on and say, I'm a meaningful user. If they don't do that in the first year, they can choose to wait until the next year to start out, and it doesn't actually have any effect on the total payment that they could receive.
So there are no penalties assessed basically for in regard to the first year?
Absolutely. The penalties don't take effect until 2015.
2015. And that would not reflect retroactively at all?
No.
Okay. I do want to clarify one thing, and I hope you can do this for me. You mentioned the incentives in Medicare and Medicaid, but you cannot get incentives for both. You basically have to, correct me if I'm wrong, but the physician would have to choose which one he or she would like.
Right. The eligible professionals must select one or the other. Hospitals, on the other hand, including critical access hospitals, can participate in both programs.
Okay. So hospitals can participate in both, but physicians, okay. Thank you. That's great. Dr. Mashari, I have a question about funding that was provided with the American Recovery and Reinvestment Act for HIT. Our records show that $2 billion was provided for this. How has that been utilized, and has all of it been utilized, or is there other monies out there that, and how are we going to apply that?
Thank you. Yes, the ARA provided for $2 billion for the Office of National Coordinator to help establish the infrastructure that would permit providers to achieve meaningful use of electronic health records, as well as increasing the privacy and security of such systems. We have obligated $1.97 billion of the $2 billion. The largest single chunk goes towards the Regional Extension Center program, some $720 million. To establish those assistance, technical assistance and project management facilities for small practices and critical access hospitals and so forth. There's approximately $560 or so million that went to states and state-designated entities for information exchange purposes. We have $265 million that went to beacon communities. These are 17 communities, kind of our crown jewels, and I promise the fact that 4 of you on this panel have beacon communities in your states is completely accidental. We have, and these are really the crown jewels that are showing how information technology can improve.
Oh, so when you say beacon, basically it's kind of your test, your field test.
these are communities that were ahead of the curve. Whether it's in Piedmont, North Carolina, whether it's Crescent City, the Inland Northwest Beacon community, or Grand Junction, Colorado, which are putting it all together. They have higher rates of electronic health record adoption than other parts of the country. They also have governance mechanisms and leadership to use the technologies, the redesign of physician practices, the performance monitoring and feedback, and really bringing all the tools to bear to show how health information technology and its meaningful use can show demonstrable and near-term impact on cost and quality of health care.
Thank you so much. I yield now to Mr. Richmond, our ranking member.